Well, welcome, Dr. Thomas Wang. How are you?
Thank you. I'm doing very well.
Thanks again for taking the time to join us on the Beating Melanoma project. And I'm going to just briefly introduce you. So Dr. Thomas Wang is a board-certified surgical oncologist at the Hoag Family Cancer Institute, and he's also the medical director of the Hoag Melanoma and Skin Cancer Program. And prior to joining hold on a second, I got to stop this. Good afternoon, Dr. Thomas Wang. How are you?
Good afternoon, Stephen. I'm doing great. How are
All
you?
right. Good. Thanks again for taking the time to join us on the Beating Melanoma project. And again, thank you. And before we start, I'm going to introduce you to our audience. And Dr. Thomas Wang is a board-certified surgical oncologist with the Hoag Family Cancer Institute. In addition, he's a medical director of the Hoag Melanoma Program. And Dr. Wang joined Hoag in 2022, a couple of months before I did. And prior to that, he spent 15 years as the professor of surgery at the University of Alabama and Birmingham. In addition, he was the chief of surgical oncology at Birmingham VA Medical Center. He has more than 40 original publications, and he spends a great deal of time. He has a great deal of passion in teaching his resident and medical students. In addition, he is a panel member for the National Comprehensive Cancer Network, which is the NCCN program, for developing guidelines for treating thyroid cancer. Thank you, Dr. Thomas Wang. Thank you for taking the time to join us.
Thank you, Stephen.
So, Thomas, I have to say, has been a great pleasure working with you just in the last few months and sharing some of the patients together. And one of the things, a lot of your patients, after they seeing you coming back, and they always say that they had such a great experience with you because you have somehow a very easy manner to sort of alleviate their fear. Can you just walk us through, like, what is the consultation process when patient actually come into your office with, let's say, late stage melanomas? What do you say to them?
Yeah, I think it's a very important relationship that we develop with our patients, especially cancer patients, because as you've stated, oftentimes they are very scared. The most important thing, I think, to develop this relationship is to educate our patients. Let them understand what their disease process is. Let them understand how management of cancer is different from the management of other diseases. Many times, just the knowledge of knowing how severe or how aggressive their cancer is and the development of cancer alleviates some of the fears that they have, because then they know that we have the knowledge base necessary for the treatment of their disease. In addition, when they understand the pathophysiology of their cancer, they also have a better understanding of why the treatment is necessary. And all of this results in a very good relationship, a doctor-patient relationship. And as we physicians know, it's such an honor to take care of all patients because they really entrust us with their entire body. And this trust has to be reciprocal. So not only do we trust them, but they trust us. And in doing so, we are able to provide our patients with the best possible care.
So let's delve a little bit deeper. Let's be more concrete because not everyone will get a chance to see you. And the goal I have to interview you is, so for a patient with different stages, especially late stage of melanoma, they come to see a surgeon, they can at least expect some of the dialogue, some of the conversation you have, right? So they won't be surprised when they meet their doctor. Let's take by case basis. Let's say someone who has stage 1 disease, right? We know it's relatively straightforward. And they walk into your office and you tell them you have stage 1 disease. Now, what's next? What do you tell them?
Well, this is a very frequent visit. Many patients present to us with early stage disease. And I think the most important thing is to alleviate some of the fears that have been generated once they are told they have melanoma. Because many people feel that once they have a diagnosis, of cancer, the cancer is a death sentence. And it's not necessarily true. With early stage melanoma, the survival is outstanding. Greater than 90% of patients will survive long term. And that's the first thing that I tell them, that if they are presenting with in situ disease or early stage disease, stage 1, then I let them know that they're going to do very well. The most important thing is that we have to accurately stage their disease, and stage is really just a surrogate for tumor biology. How aggressive has the disease become? And then we go into the treatment. Most of the time for stage 1 disease, it's fairly simple. It requires a wide local excision, which means that I'm going to cut out the cancer on their skin and close their skin back up appropriately. And then we have to discuss whether further staging workup is necessary. For the most part, for early stage disease, that's all they need. The other thing that I impress upon them is the treatment that comes afterwards, which I think is much more important, because I let them know that their melanoma, if it's at early stage, will never hurt them. However, because the process that causes melanoma is solar radiation, the rest of their skin could be affected, and that means that surveillance is very important. And then finally, of course, protecting the patient from developing melanoma in the future, which means sunscreen use and also protection from extensive solar damage, and then of course never utilizing a tanning bed.
No, that's all very valid, and I think you and I sort of do the same type of work for up to stage, I think, 1, because once over stage 1, and then we get into the idea of sentinel lymph node biopsy, that I have to defer to your expertise a lot of times. And you mentioned specifically the word staging it accurately. And, we talked a little bit about using pathology report, give you some information, and staging it accurately using sentinel lymph node biopsy, which is a really, really valuable procedure for prognosis. Maybe you can first walk us through about what exactly is a sentinel lymph node and how do you do the procedure? Exactly, like if you give us more details in terms of when did they come in, what to expect. So if anyone needs that procedure, they can have some idea what this is like.
Sure. Well, I don't want to give you all my trade secrets, but we can go into
Trust me, I won't go into the OR with you. And go ahead. Your job is secured.
Yeah, a sentinel node, I think the best way to describe it is the first lymph node that an antigen, such as a melanoma cell, will come in contact with. And it's the first defense in our body against cancerous cells and also against certain types of infections. Every part of the skin drains to one lymph node. And by drainage, I mean the skin has a lot of little tubules called lymphatics, and they carry antigen or a foreign body to a specific lymph node. And the lymph node is usually located in a lymph node basin, such as under the armpit, in the groin, sometimes in the neck. So our job is to find that draining lymph node called a sentinel lymph node. And why that is important has really evolved over the last 2 decades. Initially, we thought that this lymph node gave us an indication as to how aggressive the tumor cell is, in this case, the melanoma cell. But I think in reality, what we've learned over the last 2 decades is that it's really an indication of how robust or how normal the lymph node is or the immune system is in preventing progression of disease. So in other words, if you have a sentinel lymph node that is normal, it contains a lot of white blood cells, lymphocytes that are able to combat the progression of the melanoma cell from growing within that lymph node. Whereas if the immune system is not normal or is somehow affected possibly by the tumor cell itself, then the melanoma cell is able to grow rapidly within the lymph node. And that's what we want to find out. We want to find out whether the melanoma has progressed within our sentinel lymph node, because that really gives us an indication of the patient's disease and, like I stated, the stage of the disease, which plays an important role as to how we should treat the patient.
So as a summary, the sentinel lymph node biopsy, the sentinel lymph node is a very, very important prognostic, give you the prognostic information, tell you whether or not this melanoma is localized only on the skin or has spread to a distant part, right? So you talked about the nodal basin. Let's say if you have a melanoma on the head, it would drain around to the neck. If it's on the arm or the back, it would drain to the armpit. If it's on the leg, it would drain towards the groin area. Now, with that information in mind, can you just describe it for us? What is that procedure like, and
Sure.
How does it work?
Yeah. The way we find the lymph node is the day of the surgical procedure where we're excising the melanoma. We also have our nuclear medicine physicians inject the site with a radio tracer. And this radioactive tracer then travels through the lymphatics, just like if it were a melanoma cell. And then it progresses through the lymphatics to the sentinel lymph node, the first lymph node that the lymphatics would come in contact with. And that would be located in one of the lymph node basins.
Like the armpit.
Right, like the
Okay.
armpit or the neck or the groin. And then the patient is then taken to the operating room. And in the operating room, I have this little Geiger probe, I call it. And I'm able to find the radioactivity where it's the strongest. So this substance that is injected remains within the lymph node. It's a sulfur colloid that remains within the lymphatic system in the lymph node. So I'm able to trace the radioactivity to this lymph node. And then I make a small incision over the area of the highest radioactivity counts on the skin. And then I investigate this lymph node basin to find the lymph node utilizing my Geiger probe.
When you say investigate, what does that mean?
I make an incision and then I explore the area, and utilizing my Geiger probe, I find the lymph node that has the highest radioactivity counts.
Got
And
it.
it may be more than one, because oftentimes we'll see that there's some redundant pathways of the lymphatics and may go to several lymph nodes. So we remove all the lymph nodes until the lymph node basin decreases to less than 10% of the highest radioactivity counts within the sentinel lymph node. And that's when we know we finished the search for our sentinel lymph node.
Got it.
All the lymph nodes are then submitted to pathology. One common misconception is that patients get this injection and they think, oh, it's gone to my lymph nodes, so that means I have metastatic disease. I want all my patients and make sure during our consultation that they don't feel this way, because this is a normal process. So everybody has a sentinel lymph node on every part of their skin. And our job is to find that lymph node so that we can give the whole lymph node to our pathologist. And then it's the pathologist's job to section through the lymph node, do their special stains, and determine whether there are any melanoma cells within the lymph node.
Yeah, so this is very, very important, right? Because we talked about, there's something called a clinically occult lymph node involvement. So that's what you do using a sentinel lymph node biopsy procedure to find that quote unquote occult, which means you can't feel it based on clinical exam. And the problem is that once you find the lymph node is positive, you get upstaged, right? And that becomes stage 3, you have lymph node disease. Now, before we get into what to do in that situation, stage 3 disease, let's step back. Is there a specific criteria that you use to decide which patient will go for the lymph node biopsy, which patient do not need the sentinel lymph node biopsy?
Yeah, that's a great question. And this is something that has been answered through evaluation of many, many patients. The development of this procedure allowed us to determine the likelihood of a lymph node basin harboring more disease. So that was the justification of performing the sentinel node biopsy initially. We in doing so, we found that there are certain patients that don't need a sentinel biopsy because they have very, very early stage disease. So the likelihood of them having a sentinel lymph node that's positive is almost zero. And these would be very, very thin melanomas or non-invasive melanomas such as melanoma in situ. So I don't do a sentinel node biopsy unless I have disease of the original melanoma is a specific depth of invasion.
What's the depth? What depth are you using?
The criteria we use for determining sentinel node is based on a depth of greater than 0.8 millimeters in thickness or less than 0.8 millimeters in thickness, but there's presence of some poor prognostic factors such as ulceration of the melanoma. So any melanoma that is ulcerated or melanoma that is 0.8 millimeters or thicker in thickness, we would do a sentinel node biopsy.
And you mentioned, I mean, I think this is all great information because it's in line with the AJCC guideline, right? And but you talked about the depth and you talked about ulceration, but what about mitosis, the mitotic rate? Does that come into play?
It used to. We used to use that as a criterion, but we no longer use the number of mitoses as a criterion for determining melanoma, for determining whether a sentinel node biopsy is necessary. And that's probably because further evaluation of the data showed that the number of mitoses didn't matter. It was more correlated to, as far as a sentinel node being positive, more correlated towards the thickness of the melanoma and whether there was ulceration.
No, it's all a great point. And also, I think there's a mathematical percentage probability, right? And I think the probability of using number like 1 millimeters above is like you need to meet at least 10% of the 10% of the time when you meet those thickness, and you will find positive lymph node. In other cases, less than 10% or 5 to 10%, and that becomes a question mark, basically.
Right, exactly. And we usually think of it based on the data, it's probably around 5%.
Yeah.
When we do a sentinel node biopsy,
yeah,
5% or greater.
And so we talked about the lower limit, the lower threshold that you will proceed with a sentinel lymph node biopsy. Is there any upper limit of the breast cell thickness that you will say, you know what, we should not do this? Let's say what happened if you have a melanoma with a breast cell thickness of 4 millimeters, right? No ulceration. Will you still proceed with sentinel lymph node biopsy, or you will say no?
Yeah, that's a great question because, and here we're dealing with advanced disease, and some people would argue, why bother doing a sentinel node biopsy when these patients are more at risk for distant metastases, spread of disease to other organs, and the likelihood of them having a positive sentinel node is going to be so high that we should just assume that they already do and just treat them like they are advanced patients that need systemic disease. But interestingly, these patients, I believe, should have a sentinel node biopsy, not for the reason of determining whether they have such aggressive disease that they need systemic therapy. Most of them should. However, it's more important to assess their lymph node basin, because if they have a negative sentinel lymph node, then we don't have to worry as much for disease progression within that lymph node basin. Of course, if they have disease within the sentinel lymph node, and then we can better monitor their lymph node basin to determine when they may have a recurrence in the future after systemic therapy. So the argument for doing the procedure is really a way of allowing us to determine the likelihood of progression of disease in certain areas of the body.
So you give some criteria about, when to do the sentinel lymph node biopsy. And next question is, are there any patient you will say, you know what, maybe we shouldn't do the sentinel lymph node biopsy procedure, even though they fit the criteria? Even though, let's say if a patient comes in with 1.3 millimeter breast cell thickness, right? Normally you will say, yes, we will proceed with the procedure. But are there any exception to the rule?
Definitely. I think it's important to realize that every patient is different. We individualize our treatment, we individualize our surgery based on the specific patient that we're dealing with. So, in other words, if we have a patient who is elderly, 90 years old, with a lot of comorbidities that can't tolerate general anesthesia, then we may say, okay, this patient will not benefit from a sentinel node biopsy because of the fact that the likelihood of this disease progressing within this patient's lifetime is fairly low. The other reason would be that this patient would not tolerate systemic therapy such as immunotherapy. And then in a case like that, doing a sentinel node biopsy wouldn't be advantageous. The knowledge of whether this patient has a positive sentinel node so that we can go on to treat the patient with systemic therapy is negligible.
So no, I think this is very important point. Like I think every time as a clinician we try to order a test, we should have downstream planned that whatever test, whatever information we're getting, we should be able to act on it. Right? If you're not going to plan to act on that information, perhaps we should think twice about not even ordering the test.
Exactly right.
And I think there's, sorry, I interrupted you. Please go on again.
If the findings don't change the management, then
yes,
it's not necessary.
Yeah, I totally agree. You and I have the same philosophy. And also, I think this is something else very interesting. Now, we sort of ran through the various criteria, everything else, but this is just give people a general sense about what their physicians may recommend. But at the end of the day, it is every patient is specific, every medical case, every situation is unique, right? So you really have to work with your surgeon to figure out, work with your surgeon or work with your physician to figure out what is the best path forward.
Exactly. Definitely.
Yeah. All right, so let's come back, right? And let's say a patient with 1.3 breast cell thickness melanoma, no ulceration, and you did the lymph node. So let's say found the arm and you did the lymph node biopsy and it was negative. So at this point, the patient remained as stage 1 disease. That's fantastic. You don't have to do anything, follow up routine basis with the dermatologist, with you, and get the scar checked. And that's one course of direction. Unfortunately, let's say if a patient, you did this procedure, they found the lymph nodes positive. Now at this moment, they got upstaged from stage 1 to stage 3 at this moment, right? Because they have lymph node involvement. What do you do at this point? And do you, a surgeon at this point, still proceeding with complete lymph node dissection, or this is at this point obsolete?
A lot of this has changed, especially over the last 2 decades. The understanding, I think, probably the biggest advancement is the better understanding of this disease. In the past, we probably thought of the cancer, of melanoma, cancer in general, as a cellular process. But in reality, it's a supracellular process. The sentinel lymph node provides us information of the patient, not just the cancer itself, which means that, and what I'm getting at is understanding that cancer and melanoma in specific is an immune disease. So if this is true, and it's not just a cellular process, then trying to take away the patient's disease with surgery is probably not a prudent approach. So I don't do a lymph node dissection on everybody. In fact, I think it's probably not necessary. And that's really based on a tremendous amount of data that we've acquired.
I'm going to interrupt you for a second. Before we even jump into the data, can you just describe when you say lymph node dissection, and I use the word complete lymph node dissection, can you just describe what this procedure is?
A lymph node dissection, in contrast to a sentinel node biopsy, is removal of all the lymph nodes within the lymph node basin. So if we're talking about the neck, a sentinel node that was positive in the neck. In the past, we would do a radical lymph node dissection or a modified radical lymph node dissection, removing all the lymph nodes or as many of the lymph nodes in the neck as possible. Because in the past, we felt that this was the only way to cure the patient of disease, trying to get to the furthest extent of the disease so that there's no progression of disease. And we found that really the data doesn't support this. And this is based on a tremendous amount of data that we've acquired from multiple studies. With respect to other lymph node basins, such as the armpit, the same thing, removing all the lymph nodes to try and acquire a surgical cure. And then same thing with the groin, doing a lymph node dissection of the groin, meaning removing all the lymph nodes within the groin. However, knowing that now it doesn't seem to affect cure, it doesn't seem to improve survival, we don't do lymph node dissections when we have only occult disease. And you mentioned occult disease as having microscopic disease within the lymph node. It's not palpable and not seen on imaging. In fact, we find that doing a lymph node dissection in these patients probably just worsens their outcome because they can develop problems with lymphedema, swelling of the leg, extensive swelling of the leg, or wound problems after a big surgery. Instead, we think that it's better to use this data to generate a better treatment algorithm, such as immunotherapy, utilizing medication to treat these patients who have more advanced disease. That's a different way of thinking of how we treat melanoma. Instead of thinking of it as a cellular disease, we think of it more as a supercellular disease. Cancer cells are affecting our immune system or another system of the body that allows the progression of the cancerous cells.
So just to summarize, I mean, I think the current state is we don't really proceed with complete lymph node dissection because the data and all this MSLT trials, et cetera, come out to show that there's no improved overall survival, number one. And in addition, when you proceed to remove all the lymph node, you have complications like poor wound healing and lymphedema, and especially in the groin area, right? And especially considering that we have all these new immunotherapies, and also plus everything you talked about, this is less of a cellular disease, but more of a molecular and more of immune process that we can leverage immunotherapy or targeted therapy to treat this advanced stage of melanoma.
Right.
Yeah. Now, so we touched upon stage 3. What is the surgical oncologist's role in stage 4 disease?
Again, the treatment utilizing surgery for advanced disease is probably negligible, but I think we do provide important information as far as obtaining tissue. All the things that I mentioned, how a cancer cell can affect the different systems of the body, we can gain that information as to a specific cancer cell, such as a melanoma cell, and what it's doing. By obtaining a melanoma from the primary site or from lymph nodes, it gives us some information about the genetic mutations that may be present. And this is probably another great advance over the last decade, understanding the utility of precision medicine, knowing that every patient's cancer is different, and one treatment is not appropriate for every single patient. But gaining information from the tissue that we acquire can provide us information about the genetics of this patient's disease and allow us to determine the best possible treatment for each individual patient. The other thing we do for stage 4 disease is, of course, in the beginning, determining that it's stage 4 disease.
Sure.
Whether the patient needs a biopsy or whether the patient needs more advanced staging to determine whether their metastasis is a true metastasis, and also the type of cancer that they're presenting with. And then lastly, of course, we do have many patients who undergo systemic therapy immunotherapy or cytotoxic chemotherapy that are able to have stabilization of the disease. So surgery may have a role in these patients after they have finished treatment, because my belief is that surgery is not effective until we gain control of the abnormal systemic processes that are going on. And then when we can remove the remaining disease, then we can effect a better cure in such patients.
Yeah, no, I think it's very valid. To summarize, basically, if patient with stage 4 disease, you get in the tissues and you genotype the tissue, for instance, looking for the BRAF mutation, also looking for the PD-1 status, etc. And then you can figure out what's the best targeted therapy, what's the best immunotherapy, right? So those are very, very valuable. I'm going to ask you one last round of questions because we're sort of running out of time a little bit. Obviously for early stage diseases, the treatment is relatively simple. The patient can come to me, patient come to you, and we remove it, done. But for intermediate, especially for advanced stage melanoma, it gets a little bit challenging. And, we often, the patient usually can get the best result when you have a multidisciplinary team to sort of take care of this patient. And you run the melanoma board meetings, the tumor board meetings. Can you just, at Hoag, can you just describe for us what that process is like?
Sure. I think it's a fantastic tool that we use for treatment of all our advanced stage melanoma patients or complicated melanoma patients. It allows us to gather all the experts in the oncology sections of our institution, such as the medical oncologists, the radiation oncologists, surgical oncology, our dermatologists who are so adept in treating skin cancers, also our pathologists, our radiologists, so all of our experts. And then finally, we also utilize the help of our geneticists and our precision medicine team. So with all these experts, we gain the advantage of a intellect that is much greater than one individual. So I think in this world, the treatment of cancer is so complex and so advanced from different perspectives that we would be fooling ourselves if we could think that one individual can take care of everything. And so having all these experts available at Hoag, we really benefit from the best possible treatment for every individual patient.
Well, that's a very good summary of describing what the tumor board is like, right? And I think Hoag is now unique. There are most of major institutions around the country, and they all have similar type of tumor board. I've been really enjoying participating in the tumor board, and there are really some interesting dynamic cases, and we've seen some really good discussion coming from multiple different specialists and coming up with something, a unique solution for seemingly a challenging case, basically. I'm going to let you have the last word. That is, what words of wisdom, of inspiration, or hope that you want to share with the audience? Because you've been doing this for a long time, looking at melanoma, taking care of patients with melanoma.
I have very little wisdom, but a lot of words. I think the most important thing all of us are aware of is that the best possible treatment, even though we have such incredible people here at Hoag and the advanced care of patients for many, many different diseases, to me, still the best possible treatment is early detection.
Sure.
And that means that proper education of our patients so that they understand what a melanoma looks like, making sure that they also see their dermatologists frequently when they do encounter a lesion that is concerning. And then finally, also knowing that protection of their skin is very important. So I think that's the most important thing that we can provide for our patients, and that is the education that early detection is the most important factor in the treatment of this disease.
Yeah, I totally agree. I always say to my patient, early detection with prompt treatment ensure the best survival. So, well, thank you again for taking the time to chat with us, and you have a great weekend.
Okay. Thank you, Stephen.
Bye.
Bye-bye.